All right. Hello, bonjour, good day. Just beginning our presentation in Australia, we have a tradition of acknowledging the traditional owners of the land, the Jagera and Turrbal people where we now live, which is currently known as Brisbane, Australia. And I also just want to acknowledge all Indigenous identified Canadians in the room, including First Nations, Métis, and Inuit people. Just a few disclosures. We do diversify funding to deliver on our vision and our mission. And we do acknowledge that pharma sponsorship can be a trigger for some PLHIV. So just briefly, I'll give a quick intro to our org, a little bit about HIV epidemiology in Australia, and then talk about our model with our testing service. At that point, I'll pass over to Glen, who will talk about some interesting 2016 data. So about us, Queensland Positive People is a peer-based community organisation that's committed to improving all lives of PLHIV in Queensland, and we've been doing so since 1989. Our vision is we want to seek to empower positive people to lead lives that are free from stigma and discrimination. And our mission is to involve all affected communities in service delivery, and particularly the meaningful involvement of people living with HIV and the development, implementation, and evaluation of all initiatives of health promotion for HIV. In regards to the strategic aim of the organization, we are committed to the early detection of HIV. As the peak PLHIV organization in Queensland, we're really concerned about that 10% in the 90-90-90. So these are positive people that are already living with HIV, unaware of their status, and don't have access to early treatment interventions that can delay disease progression. So within our strategic goals, QP is committed to the early detection of HIV because of the health outcomes associated with that. And our particular service addresses two barriers. So we don't ask people to disclose a sexual history, so there's no clinical assessment done whatsoever about sexual or drug use behaviors. And we don't document anything either, so there's no clinical records that document that. So again, we're trying to add to the mix. In terms of the big picture of the 90-90-90, RAPID fits within that first 90, so as I said, at least 10% of people being aware of their status, at least 10% of the people that are unaware of the status becoming aware of their status. And basically, we do have other programs that fit the other 90s, which is kind of known as our Life Plus program. So there's a seamless integration between our testing services and people that are diagnosed and then immediately and seamlessly transitioned into our Life Plus program. HIV epidemiology in Australia, just briefly, as we've seen in Canada, Europe, and other parts of the world, over the past 10 years, roughly, there's been a bit of an increase, and that kind of fuel among MSM, and that fuels the optimism about a biomedical prevention intervention opportunity like PrEP. So in Australia, it was no different, so a bit similar. So I guess I'm not interested in talking about combination prevention today, but I do want to just emphasize that we really see ourselves positioned quite firmly within secondary prevention, and that's a commitment to investing in the early detection of disease. So when we say 90-90-90, it's just rhetoric if we don't have a meaningful way to somehow deliver on that. So when we went about developing our model, we didn't want to replicate or duplicate what was already there. We didn't want to use peers and then do a clinical assessment and ask about risk behavior, because then we can prove to government that, yes, we targeted people who were at risk. So it's a real opportunity to think, what else can be done? How can we be creative? And I guess in a measure about whether or not we're successful is seropositivity rates. And again, we've been able to prove that, which I'll talk about in a moment. So just to prove my point about, I guess, the importance of an alternative model, we advertise as HIV testing without the full Q&A. We're across all the sex sites. We've got profiles. We post on Craigslist, which is academically proven to attract the most people that least identify with the community. Those are people that often don't have HIV prevention messages sent to them or that they see. So this is a sex worker offering bareback sex on PrEP. So again, if someone is in that sort of scenario, I'm sure a lot of people of you can imagine some of the discrimination they may face in healthcare settings if they were to be honest about what was going on. We also see a grassroots campaign in Melbourne that came out in the last year, You Can Fuck Raw, and it was just posted in alleys and on streets and so forth. And again, this is community demanding PrEP access and raising visibility. But in this rapidly evolving era where we've got chemoprophylactic barrier by positive and negative men, and where condoms don't necessarily always fit into the picture, we need to create safe and alternative spaces that clearly acknowledge that you can talk about this. It's safe to talk about this. Yeah, I just ask you all to reflect on whether or not you can imagine some of the discrimination people may feel. So does it work? This is client numbers per quarter, so we've been going up steadily as word of mouth builds over the last 2 years. We advertise through a variety of different methods and recruitment strategies. As I said, we troll through all the kind of sex sites and advertise ourselves as a safe space, regardless of people's risk, and they are let them know that they don't have to disclose if they don't choose to. And it succinctly delivers our message, HIV testing without the full Q&A. We do support a range of models, clinical, community, peer. We're just one of the mix. Our thing is that we don't take notes, as I said, we don't do the clinical assessment. It's part of the picture. And the key thing is we don't prioritize understanding the risk. And that's a real shift away from the way things have been done, because we want to know how many partners are they having and so forth, and all of this curiosity about what they're up to. We don't care, frankly. What we've argued successfully and gotten funding for is to ask our clients about key health promotion messages that are relevant now in a 2016 era of treatment as prevention. And Glen will talk to that data in his slides. And there's some really interesting stuff. So we're more focused on the perceptions around HIV and how that relates to community norms and stigma, rather than saying 80% of our clients had more than 10 partners. It's not helpful. So what are we? We do target. Fabulous, thank you. So what is RAPID? Basically, we do meet Australian regulation. We are trained to use the RAPID test. We're all trained in suicide prevention. We distribute sterile ejecting equipment, so we're all trained in harm reduction principles and minimization. And we are an NSP, so we distribute the equipment, of course. As I said, we do target MSM. Those are the sites that we go to. However, we are inclusive of everyone. And I think the key message that shows this is that we diagnosed men and women, gay, bisexual, and straight, even though the vast majority of our clients are MSM. So some of the people that come from other groups are actually seeking out a safe space. They're the forgotten part of this puzzle. And just as a snapshot about whether or not we're wasting resources, which we're often asked to do, you know, when you're getting funding, we diagnosed just over 13% of the entire state's HIV diagnoses in 2015, and we were less than 18 months old at the time. So there was definitely a craving for this in the community. I've talked a little bit about being inclusive of all individuals and not just being exclusive to MSM populations. And this is a CD4 count at time of diagnosis in Queensland. And women, as you can see in the red line, are often well below that of men. And as I said, we have diagnosed women, and they have found us to be a safe space to be. So we don't just sit there and do nothing. We go through key messages. Glen will go through some of the data, but basically we want to make sure that they understand contemporary HIV, that it's manageable, knowing that they've got options to remain negative, like PEP and PrEP and condoms, and as again, we're an NSP as well. I do want to acknowledge that QPP is committed to safe and respectful spaces for our diverse target populations that are at risk for HIV. Sexual orientation is strange because the only way it exists is in reference to a binary. So how do we use this binary-oriented thing where it's referenced to male-female when we're trying to create a gender continuum and a whole new range of sexual and emerging gender and sexual identities that may not be captured within strictly gay, bi, straight sort of data? But that's what we see in the literature. We struggle with it. We've found our ways to ask about gender and sex in a different sort of way that isn't identity-based, but our data does use that limiting information. The key thing is that the vast majority of our clients are men who identify that they have sex with men. And at this point, I'll pass over to Glen to talk about some of the data.
Cool. Thanks, Jimmy. Awesome. Hi, everyone. So as Jimmy mentioned, in terms of our client consultations, it is very much client-centered, and everything that is spoken about is basically driven by the client who visits, and they have an opportunity to ask questions and have a conversation about those key messages Jimmy identified before. We have a voluntary survey, which the vast majority of our clients are actually happy to complete at the end of their consultation. And so that's how we're able to glean a bit of data about different topics and things relevant to the HIV sector. Initially, as Jimmy said, people vote with their feet, and we have had great uptake of the service. This year alone, we have a sample size of over 2,600 people for our who have completed our survey. In terms of general satisfaction, as with regards to the style of the pre and post test discussion, or at least the format of the consultation, 98% of visitors to the service were pleased, and with their overall satisfaction of the experience, 99% of people were pleased with the service. We ask a lot about PrEP, given it's a pretty hot topic these days. And in terms of our survey, most respondents, more than 70%, indicated that they would be willing to take a pill to prevent HIV. However, the intersectionality of awareness of PrEP usage amongst their friends was quite low, with the largest proportion of our respondents who are willing to take PrEP actually being unaware if any of their friends were using it already. And you can see the green lines on the chart on the right-hand side indicate the not sure category, which is highest amongst those who were willing to take PrEP. This data remains interesting given that in Australia we have 3 major government-initiated programs for the provision of free PrEP in Australia, in the 3 largest states, which have actually, I believe, seen the fastest uptake of any kind of PrEP program in the world. For example, in the state of New South Wales, all 3,700 spots plus a wait list were taken within the first 12 months of the program launching. And in our own state of Queensland, a program's just begun this month with 2,000 places, and 600 of those have already been filled. We ask questions about PrEP and condom use expectancy, and we see a relatively even distribution of attitudes towards condoms whilst being on PrEP. Our peer education messages convey, obviously, that PrEP only prevents against HIV and not other STIs. And as just mentioned, despite Australia having seen fast uptake of free government PrEP programs, whilst it's not available that easily through a local pharmacy, this expectancy question shows relative indecision about approaches to condom use if a person were on PrEP. And what we hear anecdotally through our client consultations is that in Australia, stigma around PrEP usage has arrived in the country way before the mainstream use of the prevention method has actually come to Australia as well. We also look into a little bit of alcohol and drugs usage and expectancy questions, and our survey data showed that a majority disagreed or were unsure with the expectancy measure that they would be less likely to use condoms if they were drunk or high. In support of this, a majority of our survey respondents disagreed that they get drunk or high to forget about HIV or STI risks. However, still a significant proportion, almost 20%, did report that they do use drugs or alcohol. And this again speaks to the real even mix of the diverse range of clients who present at our service. It might be a little bit tricky to read again in the graph on the right-hand side, but when we added in the variable of willingness to use PrEP, we found that those same people who do not get drunk or use drugs to forget about HIV, they were the most likely to use PrEP as well. So there's those good sexual citizens perhaps still out there. And you can see this in the blue lines on the right-hand side, although it probably is a little bit hard to read if you're sitting up the back. And again, in our services, Jime mentioned, we're often under pressure to gather as much information as possible about our clients and why they're coming to test and all those, standard questions about typical people who present for an HIV test. And with our survey, a compromise, I guess, has been to ask the questions that are relevant to current policy development about things like PEP and PrEP in the treatment as prevention era. And we found that almost 70% of respondents reported that they knew where to access emergency PEP, which in Australia is from any HIV prescribing doctor, from a public hospital emergency department or a government sexual health clinic. And this type of question indicates that the majority of individuals are able to identify after the consultation, of course, that they are aware of how to access PEP in an emergency if they need it. This is really important, I think. We're here at a conference on stigma. The ultimate purpose of our organisation, QPP, of us being in the testing space, is to change the way that people think about HIV. We believe if people understand HIV in the contemporary TasP era, where both positive and negative individuals are using chemoprophylaxis barriers, people are going to have condomless sex. We're going to the underground, we're going to the sex searching sites, and we're trying to find those hard-to-reach 10%. And we're doing that with our safe, client-centered and anonymous model. And like Jime mentioned, we're getting out there on the free sites like Craigslist and your Squirt-type apps and things like that. So in our survey at the end of the consultations, when we ask people if they believed HIV is a manageable condition, we're finding that almost 80% of respondents agreed that it is. We're seeing straight away that the environment we're in is changing, people's attitudes are changing, and community perceptions and destigmatization is occurring in our community, which is good. When we talk about 90-90 targets, we often risk that's not a verb. We often risk the over-biomedicalization of the HIV epidemic. And so it's good at a conference like this that we acknowledge the social determinants of health in our target population here in Queensland, and that, like I said, we just want to contribute to the environment that enables an open and honest discussion and provides safety for people who want to disclose whatever behaviour that they're practicing. Just a final data topic. Self-testing is an alternative testing method that's gaining more and more prominence in Australia, probably is here too in Canada, and it has also been included as a priority area in our state government's latest HIV action plan. And our organisation, QPP, as a PL-HIV organisation, we have a dedicated website that outlines all our services that are available to PL-HIV, and we've decided that our new home testing program is going to be listed on that site as opposed to the anonymous rapid site, which Jime put a screenshot up of earlier. And we're doing that because we want the information that individuals access to be contemporary, relevant, and all-inclusive. In terms of asking the question of our rapid testing clients, we found that people who presented to rapid were still relatively evenly split as to whether they agreed, disagreed, or were unsure if they would prefer to test themselves for HIV at home. And that's in the graph on the left-hand side. In line with this supposed normalising of HIV and understanding of HIV being a chronic manageable condition in the community, as I just mentioned, it's interesting that of people who believe that HIV is a manageable health condition, we still see a relatively even spread about agreement, uncertainty and disagreement as to whether they would prefer to test themselves for HIV at home. And again, that just highlights the need for a variety of testing alternatives in the community. And yeah, it's a little bit hard to see, but it's the red, green and purple lines on the chart on the right-hand side. Just quickly before we wrap up, two last things I want to mention. Our service, one of the limitations is that we, as a rapid testing service in Australia, we're only able to offer HIV and syphilis testing service at the moment. Fantastic news is that from next February, we've successfully given funding to commence a research trial of gene expert technology, which allow us to test for gonorrhea and chlamydia, which gives results in 90 minutes, and it's going to be the first urban trial of that technology in Australia, which we're really, really excited about. Is that going to go? There we go. Another unique aspect of our services at QPP is that we have a newly diagnosed navigation program, which is an adaptation of other well-evaluated peer navigation models for HIV, including one that you have here at Positive Living in BC. Frontline peer support and linkage to care for newly diagnosed PLHIV or those people re-engaging with care is really important to ensure clients feel safe and have the opportunity to engage. Our rapid clinic is unique in that several of the staff work in dual roles as peer navigators and as testers, and those roles are reserved for people who are willing to disclose their positive status to newly diagnosed clients, which again seeks to enhance that seamless transition and linkage into care at time of diagnosis. Last slide is just a quick plug of a resource. It's called Talking About Treatment. If you go to that website, this was developed by QPP just under a year ago. We used a variety of characters to talk about their experiences of accessing treatment. You know, we talk about online resources, regional health disparities, and it's basically up close and personal, I guess, video to assist people who are considering accessing treatment, that they can do that in the privacy of their own home, whether it's a person who's newly diagnosed or someone who's been living with HIV for a long period of time. So that's us for today. Thanks very much. Thank you.